Hi, today I'll be presenting our quality improvement project conducted at the Children's Hospital of Michigan for the Better Assessment and Response to Croup in Kids, or BARC project. This project focuses on improving the evaluation and management of children presenting with croup in the emergency department. Croup, or acute laryngotracheobronchitis, is a common respiratory illness in young children and one of the leading causes of pediatric emergency department visits. Evidence-based guidelines recommend treatment with systemic glucocorticoids such as dexamethasone and nebulized racemic epinephrine for severe cases. However, despite these established recommendations, there remains significant variation in how croup is evaluated and treated across hospitals. Studies have identified differences in racemic epinephrine dosing, diagnostic testing, and hospitalization rates. Tests that are not routinely recommended, such as neck or chest x rays, viral testing, and laboratory studies, can increase healthcare resource utilization without significantly impacting patient management. Additionally, variation in medication timing and dosing can lead to potentially preventable hospitalizations in children with croup. The goal of this quality improvement project was to reduce resource overutilization in the evaluation and management of pediatric croup. Our specific objectives were first, to reduce preventable hospitalizations by 20% from baseline, second, to reduce the use of non recommended diagnostic testing, including neck and chest radiographs, viral testing, and laboratory studies, by 50% from baseline, and third, to increase administration of oral dexamethasone to at least 95% of eligible patients. This quality improvement study was conducted as part of a national quality improvement initiative through the American Academy of Pediatrics Pediatric Acute and Critical Care Quality Network. We performed a retrospective review of patient data, which were collected and reported using the standardized protocol for the initiative, and then analyzed independently for our institution. The study was reviewed and determined to be exempt by the Central Michigan University Institutional Review Board and the Detroit Medical Center Clinical Research Office. The study population included children between 6 months and 6 years of age presenting to the emergency department at Children's Hospital of Michigan with a primary diagnosis of croup. Several exclusion criteria were applied to avoid confounding factors. These included children with complex chronic conditions, structural airway anomalies, tracheostomy, concurrent lower respiratory diagnoses such as asthma, pneumonia, bronchiolitis, or bronchitis, recent intubation within the past year, or direct admissions from outside facilities. Baseline data was collected through retrospective chart review for patients seen between June and December 2024. Post-intervention data was collected for patients seen between January and July 2025. Patients were identified biweekly through electronic medical record review. Data collected included patient demographics, diagnosis, treatments administered, diagnostic testing performed, and patient disposition. All data was de-identified and entered into the secure AAP Quality Improvement Data Aggregator. We also tracked several process and outcomes measured, including timing of dexamethasone administration and use of racemic epinephrine prior to hospitalization. The primary intervention was the institutional adoption of a standardized croup treatment protocol. Education sessions were provided to emergency department physicians, resident and fellow trainees, nurses, and the pediatric hospital medicine team. In addition, a treatment algorithm was distributed to both departments and displayed in common clinical areas to encourage consistent use. To start off, I will go through the baseline data for our institution. In terms of diagnostic testing, the use of non-recommended diagnostic testing was already relatively low, with neck radiographs being obtained in 10% of encounters, chest radiographs obtained in 5%, making the cumulative radiograph utilization rate of 10%. Full respiratory viral panels were not performed, and blood cultures or inflammatory markers were obtained in fewer than 5% of patients. This confirms that the baseline diagnostic testing in our institution is lower than the national average. In terms of treatment, oral dexamethasone was administered to 96% of eligible patients. The overall hospitalization rate was 6.3%, and the preventable hospitalization rate was 10% for all patients. Following the intervention, we did not observe a significant reduction in diagnostic testing, preventable hospitalizations, or increased use of dexamethasone. This likely reflects the fact that our baseline diagnostic testing utilization was already lower than the national averages. However, among hospitalized patients, 50% received 3 or more racemic epinephrine treatments prior to admission. This suggests incomplete adherence to the recommended treatment algorithm. Importantly, our balancing measures showed no emergency department or urgent care revisits and no hospital readmissions for croup or croup mimicking conditions within 3 days. Additionally, the median emergency department or urgent care length of stay was 148.5 minutes, which is below the national mean. This suggests that our care remained both safe and efficient. In conclusion, baseline data from our institution demonstrated very low levels of unnecessary resource utilization at or below national averages. Adherence to treatment protocols was already high and exceeded national standards. Because of this high baseline performance, the absolute opportunity for further reduction in testing or hospitalizations was limited. Future improvement efforts should focus more on optimizing disposition decisions, including ensuring adequate trials of racemic epinephrine prior to admission and appropriate observation following the final treatment.